Good morning, everyone. Today, I present a case of vertebral artery dissection secondary to malignant hypertension precipitating a posterior circulation stroke. One of my cases that I was privileged to follow from beginning to end. A little about the background. About 8 million people succumbed to stroke in 2019. About less than one-fourth of these were in the posterior circulation. Hence, most of the data we have on strokes is based on anterior circulation symptoms. Posterior circulation strokes can be tricky because of their heterogeneity. The symptoms can be varied due to cranial nerve involvements because the posterior circulation supplies the brainstem from which all the cranial nerves originate. So it's important to understand what are the functions, the symptoms caused due to deficits in various cranial nerves and their nuclei. It is also important for the ER personnel to be well versed in the myriad of presentations in cases of posterior circulation strokes and to keep a high index of suspicion to treat such patients in a time sensitive manner. A 35-year-old male presented with past medical history of hypertension and prior left sided Bell's palsy, in addition to LVH and chronic kidney disease, came to the ER with the following complaints in addition to elevated blood pressure: acute onset dizziness for 8 hours with some blurred vision. He also developed some nausea and vomiting, as I'll describe ahead, in addition to a globus sensation for the last 2 hours. The patient was in his usual state of health until about 10 p.m. when he started having this dizziness, which was out of nowhere, which was described as the room spinning somewhat. He also had some blurriness of vision, which when I asked more about, he said he saw double of some images. He also developed this nausea and vomiting. He woke up around 4 a.m., had 3 episodes of non-bilious vomiting, and sudden globus sensation. That is what got him to the ER itself. His vitals were normal. Blood pressure was elevated at 217 and 141. On further history, it was realized that he had skipped his antihypertensives for the last 2 days. He had forgotten to take those. Systemic exam wise, everything looked normal, just to rule out any hypertensive emergencies. Respiratory, cardiovascular, and abdominal systems all looked good. Neurological exam wise, the patient was conscious and oriented times 3. However, on his cranial nerve examination, he did have some concerns for double vision, although no extraocular movement deficits were noticed. He also did have some direction changing nystagmus on both eyes. The third thing that was noticed was this left lower sided facial droop. However, this was present even on his prior exams during his prior hospital visits, as noted on documentation. And that is what becomes important. You need to realize why the stroke alert was done and what was his prior deficits. Even if this was the most obvious physical exam finding, this was not why the stroke alert happened and was not a new finding. However, on cerebellar signs, there was some direction changing nystagmus on both sides, some impaired upper extremity dysmetria, and also some subtle dysdiadochokinesia on the left upper side. Initial lab investigations were all normal. The initial imaging, including a head CT, was absolutely normal, revealing no large infarcts or bleeds. However, the CTA did reveal some concern for occlusion of the distal left vertebral artery of the V3 and V4 segments that was read out, as you can see in this image right here. In the right clinical context, this could indicate vertebral dissection, which pretty much it did, as we will see ahead. So, based on our clinical exam and the other important history of time as well as spatial distribution of symptoms, all of this felt very, very clinically suspicious of a stroke. However, we did not have a CT that revealed one. Given the strong clinical suspicion and the fact that we could not yet obtain an MRI and the treatment was time sensitive, a working diagnosis of lateral medullary stroke was made due to vertebral dissection following a hypertensive crisis. At that time, a decision was made to allow the patient to have permissive hypertension for 48 hours to keep the blood pressure below 220 over 110. He was DAPT loaded dual antiplatelet therapy with aspirin 325 and Plavix 300 and atorvastatin 80 milligrams once daily. All that to say that he was treated as an acute ischemic stroke. Later, the next day, it was revealed on the MRI that he did have a T2 hyperintensity on the flare with diffusion restriction on DWI, which is consistent with a new acute stroke, and a final diagnosis of left lateral medullary syndrome was made. The patient was discharged after 3 days with daily DAPT therapy for 90 days. What makes this case unique is to understand that posterior circulation strokes can be described by very non-specific symptoms like dizziness and global sensation. But if you have the correct knowledge of cranial nerves and what their symptoms can mean, you should be able to recognize a stroke based on clinical symptoms itself, even if the initial non-con CT is negative, which is often the case because CTs are not great at catching posterior circulation strokes. Also making this case unique was pre-existing Bell's palsy, which made the exam very biased initially if you did not have the knowledge that what was essentially going on, and this was not a posterior circulation stroke symptom. However, he did had simultaneous posterior circulation stroke symptoms. Important points for discussion are that the NIHS SS, which is the stroke scale, was pretty low for this patient. It was essentially 3, which is pretty low. And it is important to understand that the NIHS symptoms were based on anterior circulation strokes. And even a low NIH stroke scale score for a patient with posterior circulation stroke should not let you be biased against a patient from having a severe stroke. Poor sensitivity of the non-con CT with a high clinical suspicion should still prompt you to pursue CTA that can guide the diagnosis. Essentially, the findings should also be confirmed with MRI or MRA, whatever is relevant. Thirdly, vertebral artery dissections are treated with anticoagulation versus antiplatelet for 3 to 6 months. That is what was done for this patient. And also important to understand that a patient who is beyond a 4.5 hours window but woke up with these symptoms should be a candidate for wake-up stroke protocol, which wasn't the case in this patient. To conclude, malignant hypertension can trigger vertebral artery dissection leading to a posterior circulation stroke, which has ambiguous clinical presentations and often missed on a non-con CT. If clinical symptoms are suggestive, CTA should be obtained alongside MRI and MRA if necessary. Treatment decisions are complicated by choices between anticoagulants and antiplatelets, but antiplatelets are usually preferred due to their safety profile.